In this part, I will be talking about interpretation of visual fields. Never interpret visual fields in isolation. It should always be correlated with fundus. I developed a perimetry-based classification for PYAGs, and this classification is very useful to set the target IOP and also to have proper baseline fields for progression analysis. It is divided into three types. Type 1, glaucoma starting outside 10 degrees. Type 2, glaucoma starting within 10 degrees. And type 3, glaucoma starting outside and within 10 degrees. In type 1, the disc almost looks normal, and on careful examination, we may see violation of ISNT rule. In type 2, the notch will be prominent along with the RNFL defect. In type 3, almost the rim will be absent along with RNFL defect. This slide will tell you how important it is to identify the artifacts due to the reliability indices. False negatives, 80% will have a field defect like this, and the fixation losses 2/14 with false negatives 4% have a field like this. But when the fixation losses, false negatives and false positives, when they become 100% perfect, the field is looking almost normal. Now I will be telling about eight cases how to interpret the visual fields. This is the case 1, the strong family history of glaucoma, and the IOP is around 20. Then ask for visual fields, the 100% perfectly done field, and both printouts are showing localized scotomas, which will fulfill Anderson's criteria. But if you examine the edge scotomas, they are all absolute scotomas. Whenever the edge scotomas are absolute scotomas, always repeat the test, and they may be rim artifacts, and when repeated, the fields became normal. And very well done field, and OCT is also showing normal. But since the strong family history, keep the patient under observation and review the case once in a year. Case 2, this is also strong family history of glaucoma, and the tensions around 20. When the fields were taken, there is a localized field defect in the lower nasal quadrant, and it is a relative scotoma, and repeated fields also, the field defect is consistent, and when repeated with OCT, it is showing the thinning of the RNFL corresponding to the field defect, and the patient kept on single drug therapy and is very stable till date. In case 3, there is RNFL defect with suspected notch. That means it is an established case of glaucoma, and when the IOP, and in this case the IOP is around 20, so it is an established case of glaucoma. In established case of glaucoma, our aim is to set the target IOP. See, a relative scotoma is also producing RNFL defect. Now look for the deep scotoma. The deep scotoma is this point and progressing from here towards the center and away from the center. And so the glaucoma started outside, single drug therapy put on, the patient is stable and followed till today. In case 4, this is an advanced glaucoma, and asked for fields. The 24-2 is showing almost the upward segment, almost all the absolute scotomas, and the lower segment also started involving, and with a mean deviation of 15 dB, and there are absolute scotomas within the among the 16 points in the central degrees. The field that repeated the test with 10-2, and the 10-2 also almost they also become absolute scotomas in this quadrant, in the nasal quadrant, and the superficial scotomas in the temporal and the lower nasal have disappeared. That means all the 3 quadrants are now involved, and in this case at this stage, I did trabeculectomy, and with a single drug, the patient maintained the tensions below 15, and the fields became stable within 2 days. Case 5, there is a nerve fibrillary defect, and there is a definite RNFL defect is there, and asked for, and the pressures are around 16, and asked for visual fields. The probability parts are showing few significant scotomas with p-values, and when it is analyzed, the depth of the scotoma is corresponding to 22 and 16, the last, and actually that means the deep scotomas are on the 3-degree point, and that means the glaucoma started within 10 degrees and it is progressing outwards. Suppose if you see the probability plot, if you don't see for the depth of the scotoma, you cannot identify where glaucoma started. So the importance is look for the deep scotoma to identify where the glaucoma started, and when there is a definite indication, even though the mean deviation is only -4, the definite indication for 10-2, when the field is repeated with 10-2, almost the points on 3-degree, 5-degree, 7-degree points are showing the gross loss of retinal sensitivity. And if you observe, the loss of retinal, the disease process is progressing towards fixation. So you should be very alert. Since the IOP is only 15, these are all anti-disease. Most of the glaucomas starts within 10 degrees. Most of them are normal tension glaucomas. So beta blockers are contraindicated in these cases. Even the patient is hypertensive, and for beta blockers for systemic control of hypertension is also contraindicated. And you have to try to avoid, and you work with the physician, try to avoid systemic nocturnal hypotension in these patients, and we have to work with the physician to control the progression. And because the field defect is going towards the fixation almost, I did trabeculectomy at this stage, and keeping the drugs with 2-drug regime without beta blocker, the fields are stable. This is the case 6. There is a definite absence of the rim with an nerve fibrillary defect, visual fields, and if you see the probability plot, it looks as if it's a single scotoma biarcuate with deep and superficial scotomas. But when you see the pattern deviation probability plot, the superficial scotomas they disappeared, and the deep scotomas, 2 isolated deep scotomas are highlighted, and what do we see? The same thing is seen in the grayscale. That means it's a multicentric origin of glaucoma. And now we analyze these 2 scotomas separately. This outside 10-degree field, it is showing a deep scotoma of -27 here and started from periphery to center. And if you analyze the field defect in the center, it is actually the 3-degree point is showing -27. That means the glaucoma started. From this, we can know that it started at the point at 3 degree, and we have to ask for 10-2. And the field is repeated with 10-2. And this is a 3-point with absolute scotoma. And you see the points on this is the 7-degree circle points, this is the 5-degree circle points, 3-degree circle points. This area is involved with the deep scotomas. But luckily in this patient, the progression is not towards fixation. Luckily it is away from fixation. Since the pressures are in this case are 21, and the pressures must be kept around 15, and we should see that both the fields in 24-2 and the fields in 10-2 must be stable, and we have to analyze the visual fields 10-2 and 24-2 in the follow-up test in this case. This is the field of another patient followed from 2011 to 2000 date, and in this case the 24-2 the field is stable, but in 10-2 the field is progressing. So we have to keep the pressure still more low, otherwise you have to go for trabeculectomy to see that, to arrest the progression in the 10-2. This is the case 7. In this case, I followed this case from 2005 till date. In the initial up to 2016, I thought that it is a single localized scotoma started outside, and I missed the absolute scotoma and the 3-degree point. I thought that this scotoma started from the periphery and coming to the center. I did not repeat the test with 10-2 till 2016, when the patient is told that he is not happy with the central vision. When I repeated the test with 10-2, to my surprise, I found a huge scotoma is passing between the 3-degree and 9-degree point, which is not evident in the grayscale of 24-2. So it is very, very important to identify even the significant loss around the 16 points in the central 10-degree area of the 24 or 30-2. Then we have to repeat the test with 10-2. Another most important thing is the role of OCT, ganglion cell analysis, plays a major role to pick up the glaucomas type 2 and type 3, where the glaucomatous damage starts within 10 degrees. Even the OCT, it will show thinning of the macula towards the fovea. That is an also indication for 10-2. Then to actually the 24-2C point pattern is developed, not to miss the indication to repeat the test with 10-2 by providing 10 more additional points in between the points 3-degree and 9 degrees. So, but the test is repeated with both point patterns of the same patient. But in this printout, both are showing the absolute indications to repeat the test with the 10-2. I want to emphasize one most important thing. The 24-2C point pattern is not the replacement for 10-2 point pattern, because the 24-2C also has no points within the 3-degree. So if glaucomas within the field defect details cannot be picked up by 24-2C. And this slide tells about the macular program, which is most underused. In advanced cases, for the follow-up to know the progression, we need not repeat 10-2. And if you do with the macular program with size 3, the macular program, which is nothing but the 16 points within the 3 degrees of 10-2. So we can know the progression from the 10-2 from the macular program, and it saves a lot of time. Thanks for the Maharashtra Ophthalmic Society for giving me the opportunity to share my knowledge with you all. Actually, this is a huge topic, minimum requires 3 hours, but I try to cover this within less than 15 minutes. Thank you.